Now, I understand that you're quite happy to be called Bruce.
Yes, sir.
Now, before you're sworn in, Bruce, I think you want to say something, Miss Richards, generally about the next few days.
Sir, yes. So, unsurprisingly, given the nature of the evidence we'll be hearing this week, the statements of those who are giving evidence this week contain criticisms, sometimes significant criticisms, of individuals and organisations, in particular government, ministers, civil servants and the like. In accordance with our usual processes, those criticisms have been notified to the bodies or individuals concerned, but through no fault of their own, because of issues relating to timetabling, they've not all been able to respond. And I'm just mentioning that because there may well be criticisms that are disputed, that are voiced in the course of this week, and I simply draw attention to the fact that we anticipate receiving some responses, at least in due course, from those who are criticised, and they will of course be disclosed and published.
So people who are listening should draw no conclusion from the absence of a contemporaneous response, if there isn't one.
Exactly.
Yeah. Very well. Well, let's swear you in.
Please state your full name.
Bruce Robertson Norval.
And repeat after me. I do solemnly, sincerely,
I do solemnly, sincerely,
and truly declare and affirm
and truly declare and affirm
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Now, if you need a break, and I understand there are reasons why you might need one, please indicate, and we'll take a break immediately.
Thank you.
Bruce, you were infected with hepatitis C as a result of treatment with blood products for your haemophilia.
Yes.
And you've given a statement to the inquiry about your personal experiences, but also a statement covering your work as a researcher and as a campaigner.
Yes.
In terms of research, you've been involved in, over decades, in researching matters relating to the causes and effects of the blood contamination disaster, and we'll be speaking about some aspects of that research today. You've also actively been involved in campaigning for answers over the decades, and I'm going to be asking you about that campaigning work as well. I just wanted to read something that you said in your personal statement about your campaigning and research work, and just see if that accurately captures the context in which you give your evidence today. You said in your first statement, I regard myself now as an expert patient and think it is reasonable to regard myself in this way. I can narrate the history of this disaster, not because I wrote it, but because I lived it and I have worked to understand it. I was there at the beginning of this campaign, and I'm one of the few fortunate ones to still be alive at the end of it. There are few of us that fulfil that criteria. I think it is important that the voices and questions of campaigners are heard within this inquiry, that the reasonable questions that we have all asked for decades are finally addressed, and that this inquiry is willing to hear from people like me who will challenge it, who will ask questions of it, and who will push it. Also, my campaigning has meant that I've been in contact with many people, many friends who are no longer with us. I feel that I can tell their stories as well as mine, and that their stories also need to be heard. Does that accurately convey the perspective with which you bring your evidence before the inquiry today?
Yes, it does.
Now, Christine, your wife, gave evidence to the inquiry in July 2019 and told us about her perspective and your family's perspective on your infection. I'm not going to go over the detail of that, but I just wanted to ask a handful of questions about your own personal experience to try and understand what's led you to focus on particular issues in your research and campaigning activities. So the nature of your haemophilia, is it haemophilia B?
Yes.
And in terms of its severity, how would you classify it?
Officially, it's moderate.
Is this right that there have been significant periods of your life where you've not needed treatment and not had treatment?
Until I was in my 20s, bleeds were either surgical or traumatic. So football, falling off a bike, tooth extraction, yeah.
And is this right? You've therefore had a particular interest in trying to understand whether your infection and the infection of others in a similar position could have been avoided.
Yes.
You were treated, I think, at a number of different centres: Edinburgh, Inverness, Dundee, London, Sheffield, and then back to Scotland. Is that right?
Yes, that's correct.
And we may touch on some of your experiences there. In terms of the treatment that you received when you did receive it, has it largely been with factor 9 concentrates?
It's exclusively been with factor 9 concentrates, yeah.
And mostly factor 9 concentrates manufactured from PFL in Liberton?
PFC, yes. Yeah.
Sorry, PFC. But with, I think, some commercial concentrates.
There was a commercial concentrate in '84 for a single blade, and then when I moved to England, they were using commercial 9 when I moved down here in '85.
What, to the best of your knowledge, were your parents told about the risks of the products that were given to you during your childhood?
It might give you a touch of hepatitis. That was the phrase, a touch.
And I think you've explained in your personal statement that they effectively were led to believe that anything that you got would be mild.
Yes, and transient, yeah.
And when you yourself became older, into your teens and beyond, were you ever given any information about the risks of treatment?
No.
And is this right, that again, that personal experience of yours has led to a particular interest in issues of consent and the question of what information should have been provided to patients?
Yes.
Do you know, Bruce, if you were involved in research over the years?
No, I was signed up as a research subject to the first ever Hep C test, which is why I know I had Hep C before a lot of the other guys did. Since we've been going through evidence packages, I think I've found myself on a couple of documents detailing research in Scotland on factor 9 haemophiliacs, but it's very difficult to tell, and there's so little of my notes missing that, so much of my notes are missing that I can't really marry it up, so it's just a guess. But factor 9 being so rare, there wasn't many kids that in 65 would have been born in 65. So there's 2 documents that appear to be researching my outcomes from my treatment.
And if you were involved in either of those research projects, or indeed any others, would it follow that was without your knowledge or your parents' knowledge, as far as you're aware?
Yes. Yeah. The one possible bit of consent that was given in '75, which was a tolerance test, to see how long the factor stayed in my system. But that's about the only one that I remember that my parents consented to. I was about 10, 11 at the time.
Now, you've alluded to the fact that you learnt about your hepatitis C infection earlier than some others.
Yes.
And that was, I think, at St Thomas's Hospital in September of 1990.
Yes.
Could you just tell us how that information was provided to you?
I actually went to St Thomas's on the advice of Dave Waters from the Haemophilia Society. I had problems with holding down jobs. I'd been unwell, and I was really struggling. Christine, at the time, my girlfriend, kind of pressed me, went to see Dave Waters. He arranged for me to go to St Thomas's. It'd probably been the first time I'd touched base with the Haemophilia Centre for about 4 or 5 years. And he started to aggressively look at what was going wrong with me, changed my haemophilia treatment significantly, and then asked me if I would take part in a clinical trial for this blood test.
Is that Professor Savage?
That was Jeff Savage, yeah. Asked me if I would want to take part in a trial which was properly consented, which did have the proper information, but I was told that I was unlikely to test positive. So when I did test positive, it was a bit of a shock. I thought I was just acting as a control for a test.
And how was the fact of the positive result communicated to you?
I was on my way in for twice weekly blood tests while they were trying to get on top of my haemophilia. My body destroys factor IX very quickly, so it doesn't last very long. They were trying to work out if they could do something about it. So twice a week I would go up to St Thomas's Hospital, go into the hospital, have bloods done, check factor IX, have bloods done after. On the way in, I bumped into the senior registrar, whose name I won't use, and I said to him, well, that blood test that you took off me, did you ever get the results for it? And he said, oh yeah. He said, yeah, you're positive. And just kind of walked off. And then I went into the treatment room at St Thomas's, which was, I don't know, about 2 beds worth of space. I had the needle put in. Back then, factor IX came in large 40mm syringes. It took a long time to inject. You were going to be there for 40 minutes. I was already plugged in. The doctor comes back, leans in the doorway, having told me that he was in a hurry and he was busy that day. And he says, well, look, you're positive. And I said, well, what does that mean? And he said, well, you might get lymphoma, you might get liver cancer, you might get decompensation of the liver, but it probably won't happen. What about my wife? She's pregnant. We'll test her. If she's not got it, then the baby won't have it. Don't worry about it. And then he walked off. And that was pretty much it, until my wife cornered the same doctor in a stairwell on the way to the unit to get her own answers to what had been told to me.
And the way in which you were told and the limited information you were provided with, am I right to understand that has in part fueled your desire to try and find answers and to try and find out as much information as you could about both
Yes.
the nature of hepatitis and what caused it?
Yeah, well, the observation was that for a disease that was supposed to be brand new with a brand new test, they seemed to know an awful lot about it. And I was actually doing a rotation as a nurse on a liver unit at the time, so I was able to go back to work the following day, get out the textbooks and test what I'd been told. And the textbooks weren't telling me the same. In fact, it was suggested to me by a doctor that was in the liver unit at Hammersmith that I'd probably seen the end of my medical career, my nursing career, because of my hepatitis diagnosis.
But you brought your nursing training and experience and knowledge in some respects to bear upon
Yes.
your research and campaigning, as I understand it, both because you have a certain medical knowledge already, but also because of your nursing background, you have an understanding about relationships with patients, issues about patient consent and so on.
Yes.
Just before we look at some of the specific areas of research that you've focused on, can you explain what was it in particular that inspired you or provoked you in trying to research and understand the history and background to the blood contamination disaster in the UK?
By the time I was diagnosed, which was about 23 at the time, I'd been ill for years. I'd suffered from bouts of depression, sweating, being tired, waking up in a bed that was soaking wet and freezing cold, having to change the bed at 2 o'clock in the morning. It was clearly getting worse. I would get jobs and intend to do them. Within a few weeks, I found myself struggling to get out of bed. My joints were aching, I could barely move, and my brain wasn't functioning right. So I would make mistakes, I'd get injured, lose the job. This is an area, of course, post-AIDS, where you're looking for jobs that don't have a medical requirement, where you have to declare medical conditions, because you're not wanting to go into the questions about, well, you've got haemophilia, do you have HIV, do you have Hep C? So you're looking for employment that specifically avoids those complications and having to declare yourself to your employer. As a result, probably a large chunk of them were not really suitable, but they were the best I could try and do at the time. As I say, my wife was pregnant. I was trying to be a father, I was trying to support our family. But I just couldn't get my health to behave. Every few months it would just completely collapse, couldn't move, couldn't function. And I'd been going backwards and forwards to doctors since I was 15 and saying, I've got this wrong with me, I've got that wrong with me. And nobody was giving me any answers and telling me there was nothing wrong. In fact, on one occasion, the doctor decided it was all in my head and he'd send me to a psychiatrist, which just annoyed me. So, yeah, I think Christine described it as there was a degree of relief in the diagnosis and that, well, you're not mad, you've got hepatitis. At the same point, there was a great degree of anger for me because the way that I was told, you know, it can give you liver cancer, it can give you a decompensating liver linked to lymphoma, told me that they'd already known about this for some time and I'd been literally starving in a garret at points, in fact homeless in this city, trying to make it on my own, away from the small town that I'd had to leave because of the bigotry associated with HIV and haemophilia and the violence that I'd faced in my previous home, to try and start a new life down here. And all I wanted from the doctor was a straight answer, you know, am I well enough to do this? Am I well enough to think about having a relationship? Am I well enough to date? Am I safe dating? And I'd asked all those questions countless times. So there was a great sense of betrayal as well in that diagnosis. I mean, I can remember every bit that day in absolute clarity, sitting in the dark for 3 hours waiting for my wife to come home from her work, pregnant, and not knowing how I was going to tell her, what I was going to tell her, and deciding at that point that if she decided to get up and walk out, that I was going to help her pack, I wasn't going to get in her way. So yeah, I was bereft, I was angry, and I felt like I'd really let her down, that I'd pulled her into something that, had I known this was wrong with me, I wouldn't have done that.
And so you've channeled, to some extent, that anger and your frustration at not being given answers into the research and the work you've undertaken over the subsequent decades. In very broad terms, because we'll come on to some of the details later, but in very broad terms, what kind of bodies, what kind of individuals or organisations have you tried over the years to get answers or explanations from?
Well, to start off with, I had my student nurse card. So there was the Nightingale Library in St Thomas's Hospital. I didn't hand it back when I resigned. So I had 2 years of that and being able to walk into University College London, St Thomas's, and the Hammersmith Hospital libraries and just go and look at the research documents, most of which were referenced. So you just spend a couple of hours sitting in the library reading documents. And I started from there. I then went and looked for things that I felt should exist. Simple stuff, adverse reporting, medicines inspectorate requirements, you know, is the medicines inspections match up with the hepatitis? Do they know about the hepatitis? Didn't seem to be so. Some of those documents were very early on in my life. One of the HIV litigants gave me some of the medicine inspections. And then the obvious ones like notifiable disease. Hepatitis B is notifiable disease. There should be haemophiliacs surely reported as hepatitis B. So I wrote political questions, got my local MP to do them to find out if we could get any data, core data, just to get an idea on how long is this, how big is it, how wide is it. And it became more and more obvious that core data that should exist, that would logically exist, wasn't there. Whether or not that, I've since found some of it, so whether or not that was an absence because it was never made, or an absence because it was somewhere else, I don't know. I suspect the latter is true now because certain documents that I would have expected to find 20 years ago are now coming to light.
And over the years, when you've asked questions, when you've pushed for answers, again, in very broad terms, we can look at some specifics later, what kind of response have you have you got? Have people been receptive, welcoming, transparent?
Oh, I'll give a classic one with St Thomas's. I got told by the senior registrar that I should stop referring to my. I still have a lot of bleeds in my mid-thoracic spine. By using the term mid-thoracic, he said, "Oh, doctors don't take you seriously if you use the real names for things." And I can remember being absolutely horrified. I said, "Well, I'm training to be a nurse. I've done my anatomy physiology. I know the difference between a scapula and a kneecap. Why can't I call it my scapula? Why can't I call it my mid-thoracic spine? Oh, but we won't take you seriously if you use those words. Those belong to doctors." And I can remember being so offended by the concept that I had to play an idiot in front of this doctor for him to feel satisfied with the relationship. He certainly didn't want a relationship of equality. And those kind of things lit a fire underneath me.
And when you asked questions, whether of the medical profession or through your MP or through campaigning organisations, to what extent, again in broad terms, were you ever given any kind of clear or comprehensive explanation?
Nothing that I didn't find myself. I think that's the straightest answer to that.
You told us that you learnt of your own infection in September 1990. How and when did you become aware of the bigger scale, of the numbers who were or might have been infected?
Well, the day I was diagnosed. Because the senior registrar was very clear, no, all your haemophiliacs will have Hep C. Hence being horrified to discover that most hadn't been told until 94. But yeah, I was told absolutely by the doctor that gave me the diagnosis, no, all you guys have got Hep C.
Now you've told us about some of the methods you adopted, going to the library, starting to research, looking for certain types of material. You also, I think, over the years, established links with other campaigners.
Yes.
And have worked together with other campaigners to try and, again, find answers or obtain explanations. Is that right?
Yes, the legendary phone bills, the 2 and 3 hour calls to Robert Mackey, the 2 and 3 hour calls to Hayden. We used to just, sometimes we'd rap for an hour and then we'd just discuss bits of information, check our understandings against each other on a regular basis, to the point where it was almost daily. Yeah, I mean, I'd certainly be spending, this is sort of pre-Google, pre-internet, you'd be spending maybe 3-4 hours a day on the telephone, checking what little I knew at the time against everybody else to see if we could come up with some kind of coherent narrative that linked it.
And in your witness statement, you talked about a concept of open publishing. What did you mean by that?
It's a concept in basic concept in science is that you learn from everything you do, including your mistakes, and the only way to actually bring that forward is to be peer-reviewed. So you don't just restrict it to your haematology friends. You actually publish in something like hepatology journals. You check your results against the virologist. You check your results against other specialities, not just your own speciality. And you do that through open publishing. This is what we've got. We're ignoring this side effect. Should we? Because that's the bit where I was really offended. I mean, I described it as the whole thing was like an intellectually offensive to me from the beginning. In the concepts of science, you have to leave things open. You have to dare to say, this is my findings, what do you think about it? And I couldn't see any evidence of that. And I had one episode at a Haemophilia Society event, which was run by Mr. Farling, where I was in the company of 4 of the Scottish consultants. And I asked them just a very simple question: who was your hepatology advisor? And none of them would give me a straight answer. So you also feed from those things, well, you don't want me to know who your hepatology advisor is. I really need to know who your hepatology advisor is, because there's a reason you don't want me to know. So you kind of, it's almost like a negative imprint. It's like they're trying to get you to do 1970 to now? Why don't they want you to look before 1970? You start asking these questions and you look at the data differently because you're being directed. You start asking yourself, well, why am I being directed? Why am I being told this is the story? Because it doesn't seem credible. It seems too neat. Even as somebody who writes fiction from time to time, I would be embarrassed putting a story out like that because I didn't think it was credible. So, yeah, negative imprints. You just, the things they're not telling you or the ways that they're avoiding telling you things gave me clues about what I should be looking at.
You used a jigsaw analogy in
Yes,
your statement. Do you just want to talk a little more about that?
None of this information everybody takes for granted now came to us in one big swoop. You know, there's been packages of evidence, famously the Ognall Papers, etc., got into circulation one way or another. But on the whole, especially during the 90s, Hayden had a little bit, I had a little bit, and we had this jigsaw with great big gaps in it. And you can imagine you've got the sky up there, you've got a tree down here, and you've got to try and fill in the gaps. So you would work on theoretical ways of trying to fill in the gaps, so using things like game theory, substituting different factorials within different elements of the paradigm to see what would give you a credible picture. And I spent an awful lot of time on this multifactorial swap things in, swap things out business to see if I could get towards where data might be, who should have data, where it might exist. And from there on in, because I was too well known, I then would contact other people and say, can you do me an FOI? I'll need you to write an FOI. Well, why don't you do it? Well, because if it's got my name on it, it's going to the head of the department and I'll probably just give them a shredding list. But if I get you to do it, they don't know who you are. So there's certain people I brought to the campaign where I would just say, I even did it to Alice and Robert very early on. I said, look, I can't do this FOI stuff because I'm just going to flag up Bruce Norval, what's that document, what for? But they don't know you guys. So why don't you do these FOIs? This is kind of where I think you need to go. And they just leave them off and let them go running. And that would then feed stuff back. And you build a picture.
And the jigsaw that you're trying to build, I think from your statement, it still has a lot of pieces missing.
Oh, massive pieces missing. Particularly, the early stuff's pretty clear. The middle stuff's not. The transition stuff, 50s, 60s, 70s, I've still got a lot of questions. There's bits I haven't been able to fill in. There's elements of compounding factors that I haven't quite got my handle on during the war, but I think they must be there, and there are things that I certainly would like the inquiry to consider looking further at.
And are there pieces that, I don't want to overplay the jigsaw analogy, but it's quite a useful one, pieces that you think you've slotted in, but which you might have in the wrong place?
Yes. Yeah, I mean, it's very possible. I mean, we started with nothing. We didn't have a single piece of paper. We had a series of stories with a group of old guys sitting in a room, all pretty angry, mainly mentally unwell, because we all were pretty mentally unwell at that period of time, who would give you stories about, well, this was my interaction with my doctor, this is what he told me, and you go, well, yeah, but that doesn't match. And you start getting these incongruities. The incongruities in themselves create a picture, and you start digging into that. But I mean, it could take you a year just to dig out one piece of that jigsaw. And then where does it go? You know, it's blue, is it sky, is it sea? Where does it slot in? Who knew what? How few people needed to know about this? It was just multifactorial thinking in relation to each piece of evidence as you go in. And as a result, yeah, it's quite possible I've got one or two bits in the wrong place. I think the overall and overarching narrative is pretty much right.
You've produced a number of documents with your statement. I think I'm right in understanding that, however, is a small fraction of the overall amount of material
Yes.
that you've gathered over the years.
Yeah.
And indeed, it's a small fraction of the amount of material you've provided to the inquiry.
Yes.
you focused, I know, on certain issues that we're going to come on to. But you have, I think, a number of broader concerns that you haven't articulated focused on in your statement because they're being addressed by the inquiry, as it were. So issues about medical ethics,
Yes.
Consent.
Yep.
Those are matters very much of concern to you.
Yes.
But you've as it were, focused in your statement on some of the areas that are less well trodden.
Yes. Yep. In campaigning, because there's so few of us and because we're all ill, there's no point in repetition. We'll check each other's homework. I mean, the guys will phone me up and send me documents and say, what do you think of this? But there's no point in us repeating stuff. So Alice was very good at looking at a very focused event, what was going on around Edinburgh. Other people, Bill, very good at dealing with the politics. I was kind of in and out of those things. I was more interested in trying to find out how long this piece of string was. I kept going back. I mentioned it yesterday to somebody, to a thing my father used to tell me. If you saw a piece of string on the floor and you can't see either end of it, what do you know? You only know it's a piece of string. You don't know if it's got a function. You don't know if it's tied to anything. You don't know how long it is. So I was always interested in how long is a piece of string. Everybody seemed to focus very much on drama, and I do think an awful lot of the political behaviour over the years has been deliberately designed to keep us distracted. I think most recent events in relation to so-called uplifts in the schemes, again, have been deliberately, they haven't been hashed, they haven't been rushed, they haven't been put together like that. They've been deliberately set up so that they're disruptive. They keep people focused on other things, they distract, they upset, and they knock you off balance. It's classic Westminster behaviour. It's something that I've seen repeated, certainly in my 30 years throughout our community. You sort out one group so the other group's angry with them. You pay out one group and then the other group goes, well, yeah, that's fine, really happy for you. I got the same money, but I had to prove I'm dying. So what's happening with me? They want you distracted. They want you spending the money. I mean, some of the guys, quite rightly, have had nothing for years in Wales. I started to dream about having a house, having normal lives. God, 40-year-old aspirations, why not? But it's distraction. So my brain always goes, well, you're trying to distract me. You want me to look over here. So what's down there? So I spent most of my life being, it's almost perverse. It's like, well, if you're waving your hand here, I'm looking at your other hand. Because you clearly want me to look at this hand. So I spent an awful lot of time on that. And it's something that I think myself and Hayden and Robert in particular cottoned on to. Hayden no longer being here to do it. I'm sure he would have done most of the work I'm talking about. And Robert's no longer fit enough to stand. So it kind of just fell to me in the end.
And have you kept hold of all the material you've uncovered over the years?
No. I will admit to periods of mental illness, and at one point post-Penrose, I think I probably burnt about 3,000 documents, mainly in relation to the interwar years. And I have actually spent some time since the inquiry was announced rebuilding some of those documents. So some of the stuff I have submitted to you, I did have, then I burnt it. I went looking for it, found it again. But there is bits missing. There is degrees documentation that I'm never going to recover. But I'm sorry, I was very upset. It seemed like we had just wasted years. I'd watched friends die in hope. And what we got left with was, fortunately, a First Minister who was at least willing to talk to us about some form of support. But I felt like I'd wasted a large amount of time trying to get into detail that the Penrose wouldn't let me into, looking at areas, prehistory. The haemophiliacs weren't the first blood product patients by a long shot. So what happened to those other groups? All of that stuff. I've rebuilt bits of it, and I'm hoping there's enough for you guys in the inquiry. But I did have a lot more once upon a time.
And whether from your own experiences and research or from your experiences of talking to others over the years, are there particular types of or categories of document or records or medical records that you've identified not existing or not existing anymore?
There's certain time frames that are kind of commonly missing from people's notes, which is like childhood bits. So haemophilia tends on the dramatic. So when you do get rushed in hospital, particularly if you were a bleed-only treater, it was all a bit rushed. So you remember these events, even when you were wee. I mean, it's like I could tell you where I was in the sick children's by the number of strip lights that malfunctioned between the casualty department and the children's ward I was on. Those events really stick in your head, to the point where it's like people were talking earlier on in the inquiry about using cryo and using whole plasma, and I'm lying there, sitting there up in the Highlands, and I'm thinking, I've never had those. And started treating me in '68. They only ever bought clear syringes. So it's a strange existence. You know enough about things that when bits of information come out, when somebody from another group says, oh, I've got this, your brain instantly can now contextualise it. I suppose it's 30 years of reading. One of the great advantages of being chronically sick and disabled is you've got a lot of time on your backside and your eyes still work.
I think one of the categories of documents I've seen somewhere you refer to as not having been able to find something called hepatitis books.
Oh, the hepatitis record books. I got told about those from somebody who worked for blood transfusion, because I said, how did you record hepatic events resulting from blood transfusion? I said, oh, we had a record book, a ledger that we filled in with what unit of blood, what adverse reaction the patient had. Was it Hep A? Was it a quick expression, or was it Hep B? Was it an elongated expression? Those books, I was told, were in existence right through to about 85. And then were, according to Andrew Kerr, Scottish Health Minister at the time, were universally destroyed in 85. But this is what I mean about, these documents that you would expect to exist. They're important records. They're public health documents. Anybody who works in public health will tell you that you learn from history in public health. So undoubtedly the examination we'll have of COVID will change the way that we respond public health-wise in the future. Keeping data is a big thing in public health. And something like hepatitis, which at that point was a serious problem within organic medicine, you would expect there to be a significant record. The fact that the only record that was kept was a ledger in each blood transfusion unit, and they all appear to have been destroyed in the same year, which was 85, when all the AIDS stuff really started to rise and the first legal cases started. The only conclusion I reached from that is somebody's ordered them destroyed because they would be damaging. I can't actually speculate exactly why you would do that. Twofold. One is you would have bags of blood that would be marked high risk. You don't really want to explain why you're using bags with a high risk sticker in the corner. And the other one is you would have actually shown the burden of hepatitis in the general donation pool, which then when you look at haemophiliacs where you're pooling plasma, if a single unit donation system is returning so many hepatitis cases each year, then why did you not think that would happen with haemophilia?
We'll come on to a little more about that in a moment, Bruce. I just wanted to, before I ask you about some of the specifics, just pick up again in your statement. You talk about the apparent importance of the language used by those in power. What did you mean by that?
They dropped the word virus from hepatitis sometime in the 60s. So, viral hepatitis, the notifiable diseases law, as soon as you got viral hepatitis, you're supposed to notify. They changed its name. They took viral out. They called it post-transfusion or serum hepatitis. It's no longer got virus written into it. We don't have to report it. And you could clearly see that was what was going on. I mean, we've got universal infection of haemophiliacs with Hep. We've got liver derangements. We've got Hep B. It's a major problem through the 70s. But we've got no cases reported under notifiable disease. So, yeah, these things strike you as like, it might be all right if it was one haemophilia centre. You might say, well, that was just that doctor who thought he was beyond that. But you've got an absolute coordination of every haemophilia centre in the country not complying with the notifiable disease requirements in hepatitis.
And thank you. You asked, you referred to asking a parliamentary question. Just going to see if we can find. Yes, it's BNOR 40569. Please show me. This was adverse incidents, but I think it might still illustrate the point that you're making.
Yeah.
So we can see there the question is posed by Fergus Ewing to ask the Scottish Executive how many adverse incidents regarding the use of Factor VIII and Factor IX blood products in the treatment of haemophiliacs were reported in each year from 1970 to 1987. And then the answer, the number of adverse incidents relating to the use of SNBTS, Factor VIII and Factor IX concentrates reported to SNBTS between the years 1970 to 1987 are as follows. And then if we look at the table, 1970, 0, 1971, 1972, 1973, 1974, 0, 1975, 2 in relation to Factor VIII, 76, 6 in relation to Factor VIII, 1, Factor IX, and the numbers continue, and we can see that the first year in which there appears to be a larger number is 1984, when there are 16 adverse incidents reported. Is that the kind of information you're alluding to, that you would expect it to have been?
You would expect more than that. I mean, the 1984 one that's the Edinburgh cohort HIV cases. I know why that number is 16, because I used to know most of the men that were in that group. The thing is, it's like what you don't have is specifics. This is epidemiologically, this is useless. You have a series of adverse effects, but what are they? Is it hyperclotting? Is that what we're seeing in Factor IX? And then the fact that there's nothing before 74 makes the pretense that there wasn't a factor before 74. And of course, Factor IX has been used since the late 50s. So if we were reporting hepatitis as an adverse instance, there should be cases in the 70s, certainly in 73 and 74, because we had a hepatitis outbreak in the haematology unit in Edinburgh at that point in time. So a number of us remember that one. I went home and infected my father with Hep B. One of my friends was locked in the hospital for a period of time. Why is there no cases? It was directly associated with the product, but there's none of it reported.
And then just going back to the issue of language, you've talked about viral hepatitis being replaced by serum hepatitis or post-transfusion hepatitis in terms of terminology. You've also in your statement emphasised the importance of the distinction between jaundice and hepatitis. Again, could you elaborate upon that?
All right, well, the clinically frank and the clinically recordable. Now, this is a game that was played, I think, very much through Penrose. So the clinically frank is when we turn yellow, or when we develop significant symptoms, like my friends with HIV with pneumocystis. But we were recording clinical data in haemophiliacs from the 60s. We had ALT tests, we had lymphocyte tests, all of which were recording the arrangements from the off. Those are clinical manifestations of disease. When you've got raised liver enzymes, that is a clinical manifestation of hepatitis. Hepatitis, inflammation of the liver. You're recording inflammation of the liver. The patient might not have gone yellow, but they still clearly have an inflamed liver. So why aren't you reporting it? I mean, I've heard countless doctors say, well, it was only mild. Yeah, well, they've got a bit on the back of the drugs reporting where you can say mild side effect. Why wasn't that reported as a mild side effect? They seem to have decided that unless we turned yellow, they didn't have to tell us. That was my sense of reading it. It's like, so unless the guy gets frankly sick, let's not tell him. The only reason my parents knew I had hepatitis because I had quite frank hepatitis in the early 70s. I had the extraordinary auditory hallucinations that come with, olfactory hallucinations that come with Hep B. So every time I was going to vomit, I could smell rhubarb, even if there wasn't rhubarb in the room. And as a child, I remember the rhubarb, find a bucket, I need to be sick. It used to give me about 3 or 4 minutes, but I knew I was going to be sick. Now, I know that in Edinburgh, under Davis at the time, there was a whole pile of us got sick at that point in time. My father bless him, because he worked as an electrician, always had cuts in his hands. And I presume when I split my head a few weeks after, and he put his hand up to hold a pressure bandage to my head, that my blood interacted with his. And he got very sick. He had only just started his company, and ended up having to run it from his bed. Used to, childhood memory, 20 men sitting in the living room going up in teams of 3 to be given their jobs, while my dad sat there with a sick bowl and a notepad on the other side, making sure the jobs were getting done. And that's how he had to start his business, because I took hepatitis back in the house.
We've taken it down, thank you. I'm going to ask you now about some of the specific themes or issues that you've researched or that have given you cause for concern as a result of your research. Before we look at the first document, you've talked in your statement about what happened not being an accident. It wasn't an accident, you say, in your statement in terms.
Well,
again, in broad terms, what do you mean by that?
well, the definition of an accident is an unexpected outcome, right? So it's something that you don't expect to happen. Now, you cannot conflate the idea of liver derangement, liver cancer, lymphoma, etc., as being accidental because you knew you were doing it. So each new haemophiliac that comes along and is given this treatment, you already know you're going to derange their liver results. So the idea that you accidentally do something, I described it once as putting kids on a motorway. I think it's probably about the best way to describe it. So when you've got blood products, you've got even the smaller batches, 140 donors in a batch, anything up to 20,000 donors. That's how many people's risk is reflected. I'm sure people grasp that now. You're measuring the impact on the patient in real time. You've got lymphocytes, you've got liver derangements. So you know you're doing it. So when you get a little boy who's got mild haemophilia, and you turn around to his mum and you say, I can get his ears pinned back, I've got this factor now. And his only treatment, and I'm actually referencing somebody whose name I won't use, but his only treatment in his lifetime was to get his ears pinned back, which he said was never a problem for him. It was just his mum didn't like it. He got HIV from that. You already knew the risks were there. I mean, this is 83 that it does to him. They already knew the risks were there when they started treating the kids in the 70s, because those of us that were treated in the 60s, we were already sick. You've got the deranged blood results. You're recording things in real time. So at what point can you describe something that you are knowingly observing in an individual as an accident when you're still doing the same thing to another new individual 10 years after the fact? It can't be an accident. It doesn't fit the English language description of what an accident is. This isn't an unexpected outcome. This is the expected outcome. I think the only accident was that we lived long enough to complain about it.
Now, the first document I'm going to ask you to look at is a document authored by Rosemary Biggs. It's called Memorandum on Haemophilia and its Related Conditions, a Brief Guide to Diagnosis and Treatment. Showmick, it's HSOC 40616. Whilst we're waiting for that to come up and before we look at it, Bruce, the theme or issue to which this document relates and which you've picked up in your statement, just so that others can follow the course of the evidence, is the role and significance of medical research in the treatment of those with bleeding disorders.
Yes.
And if we look together at this document, we can see the title there. If we go to the next page, we can see what this is. Medical Research Council Memorandum number 44, and the date is bottom of the page, 1974. And then if we just go to the preface, you can see it says, this pamphlet supersedes MRC, so Medical Research Council Memorandum number 32, published in 1955, takes account of all the important advances of the last 20 years. The earlier pamphlet was produced by Dr. McFarlane and Dr. Biggs, then working on the mechanisms of coagulation and its abnormalities at the Radcliffe Infirmary, Oxford, at the request of the Council's Haemophilia Committee. It was this committee that proposed the creation of haemophilia reference centres to ensure uniformity of diagnostic standards and to coordinate information. The committee also introduced the provision of special medical cards for haemophilic patients and the organisation of a registry of haemophiliacs. Now, before we look at some of what this document says, what significance have you attached to what this shows us about the relationship between the Medical Research Council and the treatment of those with haemophilia?
The MRC is a continual factor. I mean, the MRC was involved in the setting up of the Haemophilia Society. They were involved in the setting up of the UKCDO. Dr. Biggs, FMRC path, military trained, was actually one of the architects of the MRC path exam. The whole point of the Medical Research Council, ironically, is to research things. And pathology, by definition, is looking at disease processes and looking at dead things. So your interest area is disease processes. I mean, I can understand why Dr. McFarlane, who had been involved in the World War II efforts to try and reduce deaths from hypovolemic shock using Cohen's fraction, would have an interest in haemophilia, and that an extreme expression of bleeding would give you clues on how to stop bleeding in wound packs, which has actually been achieved now. A haemophilia drug called Norval 7 is used in wound packs and was used during the last Gulf War to great effect. I've even spoken to soldiers whose lives were saved by it. It strikes me that what we're setting up here, 1955 through, is actually an attempt to quantify the clotting mechanism. Understandable. You want to save lives in the field, normal clotting, etc. I can understand that you're also going to want to quantify your mistakes. And there was mistakes, and I knew about those mistakes. I knew about the Cohen's fraction issues. I'd actually spoken a number of years ago to a retired medic who lived in Fortrose when I lived there, who told me about men going to the front after D-Day. They'd been into the field hospital, they'd been treated, they'd been sent back out, frequently with, a big wound badge. We've probably all seen the British Tommies with the wound patches in the last few days. But they would turn yellow about 4 weeks later. So they kind of knew that, you're fit to fight for about 4 weeks, and then we're going to have to pull you out and let you rest. And there was points during things like the Battle of the Bulge, etc., where we had major problems, and that a large chunk of the people that were up front were physically ill. And an awful lot of these illnesses, when you look at the genesis, where they came from, they were coming from corrupted immunisations, corrupted Cohen's fraction. Very naively, as a man in my 20s, I remember as a nurse helping undress a veteran from the Second World War and noting the shrapnel across his back. And being a young lad, he just said, "Oh, where did you pick those up?" Oh, I said, "Oh, that was D-Day, son." He said, "I got them on the beach." And I said, "Did any of you get off the beach without a wound?" He said, No. He said, "Everybody got." He said, "You either got shot, you got shrapnel, He said, "Everybody had to go and visit the medic before we went forward." And it hadn't dawned on me the sort of sheer scale of exposure that this dry Cohen's blood that they'd been using had been used on such an industrial scale as we made our way off the beachheads. And it wasn't until I grasped that and started to look at other things that were happening. And I don't know if you want to go there yet, but it kind of made me jump and start looking at what would be expected pathologies. So if things go wrong, you would expect certain pathologies to start to rise after the war. The reason to look at the war, of course, is because it's the industrialisation of blood, the industrialisation of tissue medicine. So you would expect that haemophiliacs being a surprise. Well, are we a surprise? You did all this during the war. What happened to the liver cancer rate after the war? what happened to leukemia right after the war? And you start to look for these trends, and you discover things in various cancer research organisations, frequently in their historic sections, where you would see these upward curves. And then, I mean, interestingly, human T-cell leukemia, it goes up, and then it starts coming down again. So you can see, well, yeah, you've created a problem, and then most of that's died out, and you're not recreating it because it's falling off. So you've obviously solved that issue. And leukemia is one of the most marked ones, I think, post-war, once you start following them. The Americans certainly were in a big panic about T-cell leukemia in the 50s.
I'm going to come back to some of those issues, in particular some of your research around the time of the Second World War in a little while. Just sticking for a moment with this document.
Yeah.
Want to put to you what I understand you say the significance of this and other materials is, and see if I've captured that correctly.
Yeah.
The organisation and delivery of haemophilia care is you have pointed out through this and other materials, closely associated with the undertaking of research.
Yes.
And to put it in simple and blunt terms, your belief is that the haemophilia community was seen as suitable subjects.
Useful material. You've got a group of people who they've got a bleeding condition, it's traumatic, right? Mum and dad's bringing you in as a kid, they're offering you this miracle drug that's going to reduce the drama, stop you crying. I mean, the pain from bleeds, and anybody that's ever had a severe haemophilia bleed, it's extraordinary. So you are screaming as a child, right? So your parents are stressed to hell. And then the doctor comes along with this needle and says, it's a magic needle, inject you. And a few days later, your parents see you running about the ward. But you already know this material is the same stuff that you've had a problem with during the war. And you're keeping us on the ward, and you're taking bloods off us all the time. And you're not really, I mean, clotting's almost incidental to the real data you're collecting. And from a biological point of view, one of the shocking ideas is that to insult the liver in somebody with a clotting disorder means you're also depressing other clotting agents. So you must have been at least making recovery slightly more difficult, even using that drug. So there's no point at which we start treating haemophiliacs, whether it's 55 or 64, where you don't already have enough data to know that the use of concentrates, even in small pooling, is going to cause a problem. Then you have a look and say, well, what data were you collecting? Well, you were doing liver enzymes. You were doing lymphocyte analysis, full breakdowns. It's research then. You're not really looking at us as clotting agents. That's just a way to get around the Helsinki agreement. That's incidental. What you're really interested in is what we catch.
So your view is that the way in which haemophilia care was organised and delivered was in part either designed to or had the result of facilitating research on what you described as
it's a very closed system.
Material. Sorry, can I just, in terms of the transmission of and the effects of hepatitis?
Yes. I mean, but you've also got to look at the design of this. I mean, it's like haemophilia centres controlled everything health-wise. We're in a hierarchical system. Medicine at the time was extremely hierarchical. The consultants were extremely dominant. And if they told another doctor, no, this is my patient, which there was this my patient, not somebody else's patient mentality, the other doctors would then just follow the protocol given to them by the consultants. They wrote to my GP, and we got called up a few times in my childhood, frequently to be put on antibiotics, God knows what for. My GP would just be to say, oh, I've been told by the unit I need to do this. So you have these guys who are extremely powerful. There's very few of them working in a few centres. They're all trained in the same place. They're all trained in the same way. and they have total control over what your GP gets to see and what your GP then tells you. Because they'll write letters to your GP saying, oh, don't tell the patient, but you might need to know the following. And we've seen plenty of examples of that through people's notes, and that was part of what came out in my interactions with people, is that, you know, I found out my GP had been known about this for years, but had never told me. It was all about control. The more I look at it, the more I look at the mechanisms within it. The whole system is designed to funnel information into a very few number of people and to control it in a very specific way. Haemophilia centres owned us. If you went to university in a different place, your product followed you. The instructions from the haemophilia centre that you started in followed you. And very rarely would you come across a centre that would disagree with that. Probably more famously, Jeff Savage would be the one exception, who would use terms like bollocks and this is bullshit, and very much in the Lancelot Spratt, but on our side feeling vein. He was the only one that would kind of dissent from that. I mean, I only found out through recovering documents that somebody had been sending data on me for 10 years after I moved to Scotland back to Sheffield. I'd never consented to that. I can't remember consenting to anything about that. Why was data from me from Inverness ending up in Sheffield? I presume it was a long-term interferon trial, but it would have been nice to know it was happening. And you find more and more of that. You speak to the guys, you see these odd crosses over. And then simple fact is that, I mean, 63, you've got leukocyte tests, you've got LFT tests, you can measure the damage in real time. But we don't start treating haemophiliacs en masse until we've got all those tests. And the viruses that we're looking at, oh, wait a minute. So Hep B, Hep C, HIV have no animal models. You can't reproduce them in animals. So I was thinking, well, that's odd. You've got kids on a motorway, you're taking blood from unsuitable sources, you're squeezing it into these little boys, and the only viruses that we're getting, that you're studying, are the ones that you can't get animal models for. How did that happen? And then you start chasing that stuff down and seeing if there's any credibility. And these are questions that I haven't fully answered, things that I will have to turn around to you guys in the choir and say, can you find out for me? Did they go that far? It looks to me as if they did. But as I say, the original structure is about control. You've got a doctor there who's going to control every haemophilia unit, at least for 10 years, by the fact that she is senior and she is training. McFarlane, he'd have all the data from World War II based on the Cohen's fraction that was manufactured in his department for D-Day. They make factor 9 the first time out of Cohen's fraction. At what point is that a surprise then that everybody that's given that fraction, yeah, you clot, but you also get liver derangement because you've had liver derangement before, 20, 30 years earlier. So you must know these things are going to happen. And you're recording them and you're not telling the patient. And I must admit, it crossed my mind a few times that, well, maybe one of the reasons for not telling us wasn't the fact that we'd go, bugger this, you're not doing that with us. It was something that came up when I was discussing HIV with a doctor years ago about observation bias. Well, if we tell you you've got HIV, you'll die quicker. So did they have it in their heads that the purest way to examine these viruses was for the people with the viruses not to know they had them? And I suspect that there was part of that thinking in there to overcome observation bias.
And before we leave this document, if we just look at a couple of references within it, Shomek, if we can go to page 20. And we look at the first paragraph, and this really picks up upon an answer you gave a few moments ago, Bruce. It says, haemophilic patients and those with other coagulation defects are at greater risk than normal people from the trauma associated with everyday life. Since the disease is rare, it is important for the patient to have ready access to a specialist who understands the defect and who is available day and night to give advice. The disease affects every aspect of life, from infant care through schooling to marriage and the nature of employment undertaken. It is thus important for the patient to be registered at a haemophilia centre if treatment is undertaken elsewhere, the director of the haemophilia centre should be consulted. And then it says the following notes are on practical issues that concern all patients and about which questions are often asked. So that's the theme that you were just referring to.
Yes. Yeah.
And then if we go to the next page, we can then just, it's on screen. If we look at the heading, the treatment of haemophilia, and then go down to the bottom of the page, we can see then there's a list of the therapeutic materials for the treatment of haemophilia, and in the bottom paragraph, we see the reference in relation to those with factor VIII deficiencies to cryoprecipitate, and then the last few lines to concentrates. We can see Dr. Biggs saying the freeze-dried preparation is much more convenient to use, much more consistent in activity than the cryoprecipitate. The ready availability of cryoprecipitate has enormously improved the treatment of haemophilic patients, but it is to be hoped that this preparation will ultimately be replaced by freeze-dried preparations. So we have here in 1974 the recommendation for use of concentrates, the factor 8 there. If we go on to page 24, at the bottom of the page, we can see under the heading mildly affected patients, the last sentence, in fact, the control of traumatic bleeding is just as difficult as for the severely affected patient. The same precautions must be taken, the same amount of concentrated factor VIII will be needed. So the advice there in relation to those who are mildly affected. And then we can see haemophilia B, factor IX deficiency, if we go over to page 26. You can see halfway down the page, the heading, the treatment of Christmas disease, factor IX deficiency. The general principles of treatment outlined for haemophilic patients apply to those with Christmas disease. The materials for treatment of plasma and human concentrates containing factor IX, and that then continues. So is there anything else, before we look at some other materials, is there anything else from this document that you wanted to draw attention to?
No, I mean, beyond making the comment that they're clearly scaring the horses here, in that they're talking to other medical professionals, like, this patient's really dangerous. You do not want to get caught out with this patient. You give them to us. The bias on concentrates, it's more convenient. It didn't actually say it's safer. It didn't say it was more efficacious. It's just more convenient. Convenience as a reason for medicine safety, that struck me as odd. I always remember it striking me as odd. The idea that each one of us becomes severe the moment we have an accident, yeah, okay, but I remember being told that often enough. Here's the thing. Why are you not advising the patient to avoid an accident? We were being actively told as haemophilia boys, our parents were being actively encouraged to normalise us. Send us to PE. Let us ride bikes. They can treat us. They can make us better. But the truth is that the moment I stopped doing those things, I stopped bleeding. I stayed away from a haemophilia centre for the best part of 5 years. I had no need of them. I cannot be unique. My level's 2.8%. And I certainly think that the use of the drug was overplayed. And it's one of the things that strikes me when I look at the history of this, and certainly as the evidence is played out, I've watched significant sessions from this, is that the trend, as we move through the 70s, is to look for milder and milder haemophiliacs, to the point where we are then treating von Willebrand's disease with factor VIII, even though we know factor VIII doesn't really work in von Willebrand's disease. And the only conclusion I could come from that is, well, you've infected everybody else before, so you can't check to see if your new antiviral system works unless you get another group of patients. Or you can't check to see if this bit of the recipe works unless you get a new group of patients. We know the licenses were variable all the way through the 70s and almost non-existent for chunks of the 80s. This drug was not a fixed thing. It was changing all the time. It was being refined. The problem is the refinements, particularly when it comes to antiviral stuff, you have to have new versions. Well, they'd run through all of us. There's only so many of us born each year. Factor IX is even rarer than factor VIII. Suddenly you've got all the von Willis are being treated. And it's making we know it's not going to work before you do it. So what are you really doing? You're checking to see if your antiviral techniques have worked on the virus. Surely that's the only reason you're doing that.
There's a phrase or a description from Dr. Giangrandi that you've drawn to my attention. We don't have, I think it was said on a BBC Panorama, Panorama programme, The Price of Blood. I don't have it to play, but we've got a transcript. HSOC 301296, please show me. If we go to page 3, I think we can see it in the whole transcript. Yes, towards the top of the page. This is attributed to Dr. Giangrandi. It just takes one contaminated blood donation to contaminate a whole batch of factor 8. People with haemophilia can be likened to the canary down the proverbial mine shaft. If there's an infection out there, they're going to get it first.
Yep.
What was your reason for drawing particular attention to that?
Well, I've said for a number of years that this argument about British product, American product, is actually just an argument about what coal mine you put a canary down. Right? It's still a coal mine. It's still full of danger. You're still likely to kill the canary. But it's down the American's coal mine. It's not down the British coal mine. It's a British product. You're measuring the public health in Britain. You will get emerging diseases. You will things that you've missed before. You will get emerging pathologies that you might have missed before, and they'll be British. If you use an American product, you're getting emerging pathologies in America. And I think it's important to understand this is happening during the Cold War, where they're actually scared that the Russians or Chinese might insidiously attack us. I had this conversation with a very famous man called Simon Wiesenthal a number of years ago, where I asked him about this, and he said, well, they're all obsessed with insidious attack. They're obsessed with the idea that, like the Nazi plan to contaminate blood through the fifth column with hepatitis, they would attack us first with viruses, and it would be insidious. So when you're getting British product, you're measuring the insidious viral load of Britain. When you get an American product, you are getting the insidious risk from America. The argument isn't that the person is less of a canary. It's just a case of what mine you're putting them down. Do you understand that? It's literally, as a public health measure, yes, the canary is important. But let's get this understood. The difference between using American and British product is purely the act of what coal mine you put the canary down. You're still going to kill the canary. You might kill them with something different, but you're still going to kill the canary.
So I note the time, and I'm going to come to a different topic and a different set of documents, so perhaps this is a good moment for a break.
Yes, well, let's take a break then until 11:45. Now, let me say to you, as I've said to all witnesses, you're giving evidence, you're on oath, you must not talk to anyone, whoever they are, about the evidence you've given or the evidence that you think you might yet be asked to give.
Yep.
Anything else is fine.
Thank you, sir.
I'll see you back at 11:45.
Thank you, sir.